Fortunately, there are a lot of treatments for lymphoma, and it's one of the cancers that we think about curing in a certain number of patients. So for Hodgkin's disease, we have a fairly well outlined algorithm for treatment with chemotherapy that cures a significant number of patients. Some patients require radiation therapy as well. For the B-cell lymphomas with diffuse large B-cell lymphoma, which is one of the more common types, we actually cure about half the patients with chemotherapy. We also have some novel antibodies and targeted therapies, and those are pertinent not only for the B-cell lymphomas, but also the T-cell lymphomas. We're learning a lot more about the biology of lymphoma and about what signaling pathways are activated and about what antigens are expressed on the surface of the cells that we can target therapies to. And so now we're developing more intelligent approaches to lymphoma using some of these specific agents. We've been looking at ways to do stem cell transplants in a way where we don't generate as much graft versus host disease. So the major complication when you give a patient stem cells from somebody else, in this case bone marrow stem cells, is that they can actually reject the body. So the stem cells we give can generate a process called graft versus host disease. And that rejection can be serious, and it can lead to death in some patients. And so we'd like to be able to decrease the frequency or the chance that that's going to happen. And so we've used a treatment called photopheresis, which is a pretty old treatment that was actually developed here at Yale by Dr. Edelson for T-cell lymphoma. But we've used that now as part of our conditioning to get a patient ready for transplant. Then we can give the stem cells, and the chance of developing graft versus host disease is less. A patient who comes into my office with B-cell lymphoma, which is the more common type, what they would go through would be, first they would get PET scans or CAT scans to see where the lymphoma had spread to, and probably a bone marrow biopsy as well as blood work. In most instances, they would then get some form of chemotherapy or perhaps the immunotherapy that we offer. So this would involve coming in and getting infusions, IV infusions, which might be, if you just get the antibody Rituxan, that might be for 4 consecutive weeks, and then it gets repeated 6 months later. If it's a more aggressive lymphoma, they would need chemotherapy, and they would come in usually once every 3 weeks to get IV therapy. And then in between, they'd get some blood work. At the end of all of that, depending on the kind of lymphoma and where it's located, some patients would also get radiation. So radiation basically means that you come in and you stand in front of the radiation machine, and it delivers radiation to that part of your body. And that's usually done every day or 4 days a week, usually for about 4 to 6 weeks, maybe longer, depending on what they're treating. And usually you don't really have any symptoms when you get radiation. Usually you might get a little nausea, but it's pretty much well tolerated. Whereas when you get chemotherapy, you could have other complications like lowering of your blood counts, loss of your hair for some of the chemo that we give, nausea and fatigue. But generally speaking, when a patient is done with all of that, if they're cured, then they move on to actually start feeling better a couple months after chemotherapy. Some patients have to stay on a treatment like the antibody treatment that we talked about, the biological therapy. In some cases, we keep patients on that therapy for a year or 2 after, just to make sure that their disease doesn't come back. And then they come back and see us every 3 months or every 4 months to get scans and blood work, just to check them out, make sure that the cancer hasn't come back.